ladies and gentlemen. We have taken up this panel on shock in obstetrics. I'm sure I can't go through all types of shock, but we'll probably stick on to hypovolemic shock, septic shock, cardiogenic shock, and anaphylactic shock. And only some aspects of it, some practical aspect, because the whole thing is voluminous. Okay? So here I'm going to project cases which are real cases, nothing fabricated, and so we'll take it as it comes. She is a Mrs. S, a 30-year-old, married 6 years. She had an IVF ICSI pregnancy. She was referred at 29 weeks and 3 days in view of bilateral pitting pedal edema of 1 week duration and elevated BP recordings of 180, 110 with IV labetalol given to her as well as nifedipine, and then she was referred. The right thing to do, right? She was given the basic. Anand, if I may correct you, it's 1-hour panel. On admission, the patient was conscious. Her BP was 150/90. Probably the BP has come down because of what they had given in the first center. Uterus was about 30 weeks. Nothing untoward. She was started on oral antihypertensives. We started on Magself. Steroids were given. Blood and urine investigations were sent. Ultrasound showed a 28-weeker, the 1.3 kg baby. We did the investigations. Hemoglobin was about 8.8 grams. That was, what was positive was SGOT, SGPT was marginally raised. Her LDH was 564 and her urine PCR showed 3.81. So that was all the abnormal values. A repeat blood investigation showed the same trend, and so we decided to continue with the pregnancy. A review antenatal scan showed deranged Dopplers. And at 31 weeks and 1 day, she had an episode of bleeding per vagina. On examination, uterus was about 30 weeks, relaxed, good cardiac activity. There was fresh bleeding per vagina. Cervix was very unfavorable, and therefore we decided on termination. You all know it's an IVF ICSI pregnancy. And suspecting a rupture, we took her up after having arranged blood and blood products. Intraoperatively, we did a section. We found this baby was 1.32, retroplacental clots 500 grams. And because there was excessive bleeding, we had to do a bilateral uterine artery ligation. There was difficulty in attaining hemostasis, and intra-abdominal drain was kept and closed. 1 pint PRBC given. Post-operatively, her hemoglobin was 8 grams and she was shifted to our HDU. But the same day around 5 p.m., okay, suddenly she became drowsy, less responsive. Slowly we found that the BP had dropped. Her pulse rate was 138 on the monitor. Her SpO2 was about 90 on room air, and the abdomen appeared distended. The uterus was at the level of the umbilicus, and there was very profuse bleeding. And when I looked at the drain was 300 ml. There was frank blood, and soon it had increased to 500 ml. So, any of my panelists would like to take it, Dr. Suri?
Yeah, so this was a really tough case, I think, on which you were treading on fire all the time while you were keeping her on conservative management. And it looks quite obvious that after the cesarean, the patient has gone into a hypovolemic shock. She's bleeding, and probably, as you said, in the drain, there was frank blood. Yeah. So, and with the background of the help, so definitely it seems to be that there could be that she has gone into DIC.
And with these parameters, would you conserve her? Would you do something more radical? Would you think of opening her?
Yes, so definitely, you know, before opening, we have to be pretty sure. One thing is that when the cesarean was done, at the time when we closed, were we satisfied that, you know, we have not left anything, any oozers or other things? So, lot depends on that also. If the junior people have done, residents have done, we are not sure what is happening, I would go for more in favor of opening.
Yeah, there was generalized oozing, and so the one who has done the section has put in a drain and come out. I would say that was, it was so good of her. Very good thing to have done. That's what I want all of you all to know. So when we found a low hemoglobin as well as, and with the parameters of What else showed you on this, Dr. Suri, that she was probably bleeding inside?
Yes, so it was also that her BP had dropped, and then there was the frank blood, which over one
Yeah.
hour you said
Yeah,
it
another
became
200
500.
ml. Yeah, yeah.
Yeah,
True.
so that showed it is a active bleeding along with all the parameters, hemodynamic status, which showed that she is gone into shock. So
Yeah.
yes, I think after arranging all the products, our next
True.
action should be to open and
Yeah.
explore the
Yeah.
you
That's
know,
exactly
cause of
what we
bleeding.
did. The ultrasound revealed significant intra-abdominal collection in spite of the drain, let me tell you. Investigations were sent and the investigation came as hemoglobin 5.1. So what I want to tell you is don't immediately rush her to the theatre. As Dr. Suri rightly said, investigate her. It may look very obvious to you, but then it's always better to investigate, because see what the fibrinogen was 50. It was not so pre-op, right? And per platelets 40,000, her PTA, PTT 22 and 48. Her creat was 1.1, her blood urea 28. Her urine output was about 20 ml and showed a little blood staining. So we were very sure that she was probably in a DIC. We sent the ABG and it showed severe metabolic acidosis with hyperkalemia. So Dr. Suri, what are the markers in this would tell you that she was in DIC?
Yes, so it's good that you could get the fibrinogen levels done. So that with a 50 fibrinogen level, definitely it shows that she was in DIC. I think one could go for the ROTEM also in such a case. It is very useful in a acutely bleeding patient and gives us exactly,
Yeah,
you know,
we
what.
did a rotum actually.
Okay. Yes. So that would have given you lot of clues about what was the component which was causing the mischief. You know,
Yeah, I
whether-
agree with you, because whenever you suspect a DIC, we always think we should give all the blood and all the blood products in the world. But with the TEG and the ROTEM coming in, which is, could you elaborate on that for us, Dr. Suri?
Yeah. So in fact, recently only we managed one of our cases. She had a postpartum atonic this thing, and hysterectomy was done, and internal iliac ligation was also done, and then the drain was put, and then when you know, on the first post-operative day, she started bleeding from the drain. So now it was almost more than 1000 ml fresh blood, and her BP was also dropping. So we managed her entirely with the ROTEM. So when you know, the components of the ROTEM, which the you know
ROTEM
which
stands for rotational thromboelastography, okay?
yeah. So we have those, you know, the components, the FIPTEM, the APTEM, and what is the clotting time in
Yeah.
them, which we see, and what is the, you know, the clot resolution time. So those factors you see, and then you can decide whether it is the fibrinogen
Yeah,
levels which are
exactly.
low, or the platelets, or whether it is a excessive fibrinolysis which is taking place.
Correct.
So whatever is the component which is deficient, you correct, you know, that can be focusedly
And
corrected.
corrected.
Yes.
Yeah, see, for example, the fibrinogen is low, we give cryo. The
Yes.
platelets are less, we give platelets, and so on. So it will tell you exactly, so you may have to give probably sometimes just 20 cryo. No FFP will be required at all. So, you know, you can actually reduce unwanted
the
transfusion.
products, yes.
Yeah.
And here in your patient here again, the platelets are also very low. Fibrinogen is low.
Low.
APTT is also raised. So I think everything is pointing towards
Everything.
a frank DIC.
Yeah, exactly. So she was being prepared for an emergency relaparotomy. Intraoperatively, it showed massive intra-abdominal hemorrhage with the right broad ligament collection and active oozing from the right uterine artery. Totally, we had to give her about 14 bags of PRBC, 11 units platelets, and 40 units of cryo. And then, as she said, we did the ROTEM also. ROTEM will tell you what products to give in a case of DIC. So following day, the patient showed improvement and the urine output was not satisfactory. It was only about 10 ml per hour. So there was a rising creat, ABG metabolic acidosis, improving, but there was still hyperkalemia persisting. Dr. Sunil, you would like to do something more at this point of time?
Here we have a lady who has had an abruption, abruptia placenta plus or minus HELP and DIC. With that background, yes, the resuscitation part has to be really aggressive, and see that the coagulopathic control, which is nicely done, targeted transfusion therapy was given. I would just like to do little different from what he's doing here. Now that because we have availability of fibrinogen concentrate, like for example, when the patient is bleeding massively, and there is paucity of time. If you look at the best of blood banks, the thawing time for cryo FFP is anywhere between 25 to 30 minutes, and the transport time from the for the blood bags to arrive from blood bank to OT or ICU is almost about 10 to 15 minutes. So almost on an average about 30 to 45 minutes is the average time. So in that time, the patient is going to bleed further. And the TEG also, if you look at the thromboelastography, you have rapid TEG, which takes about 15 minutes, but if you want to have a complete ROTEM or TEG, it takes about 40 to 45 minutes. And a patient who is bleeding massively, the TEG can alter in the interim period. So when you have a situation like this, go for fibrinogen concentrates.
Concentrates.
Yeah, just roughly thumb rule, you can go for 2 to 3 grams of fibrinogen concentrate, which can be reconstituted, available easily in all the most of the cities, so that you can achieve hemostasis suddenly.
First. And
Yeah.
what would you do to the urine at this point of time? There's only 10 ml.
Now that this patient has had a urine output oliguria,
Yeah.
we anticipate this aspect, because when we have
Exactly.
an abruption, it's a diffuse DIC, and you have a multi-organ involvement in this patient. So ATN is very likely to ensue in this case. We need to anticipate proactively and then manage accordingly.
Would you
So
dialyze her at this point of time?
at this point of time, the indications for dialysis are only things like I would look at the pH, I would look at the lactate, I would look at the potassium. So if the pH is persistently less than 7.1 despite adequate fluid optimization, if the potassium is rising despite adequate anti-hyperkalemic measures, or if the lactates are increasing trend is there despite again adequate perfusion, then definitely it's an indication of early dialysis.
Early
CRRT,
dialysis.
yes.
I think now you'll go for an early dialysis rather than wait too long.
Yeah.
So right enough, she underwent 2 cycles of hemodialysis and because of the increasing renal function and the deteriorating urine output, she improved very well. And on post-operative day 10, she had some fever spikes. The counts were increasing. Antibiotics were stepped up. Ultrasound revealed, after all what we did, it was a large organized hematoma, 200 cc beneath the abdominal wall in the midline. Patient was stable. I decided I was not going to touch her again. Nothing done to the hematoma. The same treatment was continued, and she was discharged on post-operative day 20. So, Dr. Sunil, you would like to tell us something about hemorrhagic shock to the audience?
Again, before we go on to this hemorrhagic shock, I would like to emphasize that whenever the patient is seeing massive transfusion on table, as I said earlier during my talk, you are giving prophylactic antibiotic. But irrespective of the duration of surgery, when you're giving massive transfusion, repeat the dose of antibiotic within 2 hours, not unlike 4 hours
Okay,
like we
okay.
say. Because, and not only repeating antibiotic, escalating the antibiotic also. Because when you're giving too many PRPs, like
Okay,
platelet-rich
okay.
plasma or random platelets, we know that the highest incidence of transfusion-transmitted sepsis is through platelets.
Okay.
Because they are stored at room temperature, like ambient, 25, less than 25 degrees Celsius, not in refrigeration. So the sepsis incidence is high, so escalate the antibiotics, give antibiotic if there's massive transfusion on table, so you can minimize the sepsis part, which like fever spikes, which despite this you could have had it, but
Okay.
probably that is one thing that we need to take home. Now coming to classification of hemorrhagic shock, like the classification of hemorrhagic shock, again we borrowed the classification from the trauma, is what we see, the class 1 hemorrhage, the class 2, class 3 and class 4. One thing that you need to remember is the physiological change in pregnancy that happens, the plasma volume expansion happens in pregnancy to the tune of 50%, and the RBC expansion to the tune of 30%, and you see physiological anemia. So when you are calculating the blood volume in a parturient, it's almost about 90 ml to 100 ml per kilo body weight, unlike a non-pregnant woman, which is about 65 to 70 ml per kg. So that thing is very important. And second important thing is the class 1 hemorrhage. When you say class 1 hemorrhage, patient is lost to the tune of 15% of blood volume. And class 2 is about 15 to 30%, 30 to 40% is class 3, and more than 40% is class 4. So when the mother moves from class 3 hemorrhage, take it for granted that she is into coagulopathy, because it could be multifactorial, dilutional, hypothermia, or
Dr.
primary-
Sunil, can
yeah.
I just interrupt you now?
Yeah.
Normally, we recognize at this stage, isn't it?
Yeah.
We recognize at class 3 because when there are obvious manifestations of tachycardia along with hypotension, Yeah, fall in a systolic blood
Yeah.
pressure. So actually we diagnose most of the times at a little late stage.
Little late stage.
Little late stage.
Yeah.
Because in the initial stages, when if you had seen that, see the initial stages was what Dr. Sunil was telling us was this absolutely clinical symptoms of volume loss is very minimal TAC. Okay.
The subtle sign is all
Yeah,
tachypnea.
very subtle.
Tachypnea. Basically, if you have unexplained tachypnea, tachycardia, as I said, you see in pregnancy like mild tachycardia, but when the patient is having tachypnea with this background, then it's a sign.
So
that
in a class 1 stage, you would just give us some fluids, right?
Yeah, just fluid.
Just
Yeah.
fluid is all that you require to restore the intravascular volume. In a class 2, she's got something more, what you said, tachycardia with
Yeah,
tachypnea.
With tachypnea.
And what is this decreased pulse pressure?
See, basically, the difference between systolic and diastolic blood pressure, basically, it widens actually. That means the diastolic blood pressure is less than 40 or less than 50. That means you need to be sure, will make sure that patient is lost significant amount of blood volume. So you need to keep that in mind.
Okay. And so even at this stage, you really require only what they were telling you about crystalloids this morning. That's all that she requires.
Yeah.
But see how much she has lost, about 15 to 30% of her blood volume. But beyond 30%, then you see the clinical manifest. We see the clinical. The other one was the parameters which you saw on your multimodal. So when we see that, that is the time that maybe she requires blood. And for blood, we always have to replace blood, isn't
Blood
it?
with blood. So
That
you-
is very
yeah.
important.
So the transfusion trigger never allow hemoglobin to drop below 7 grams.
Yeah,
When
exactly.
you have a patient with ongoing hemorrhage.
And when it is stage class 4,
Class 4, you need to go for straight away component therapy. So you need to get FFPs, cryos, because as has been happening in this patient, the fibrinogen drops rapidly. So many of us have a high threshold to send for fibrinogen levels. Not all hospitals have TEG or rotom. So if you don't have that, nothing much to worry. You can go always by thumb rules, work most of the time. Even to this date at Fernandez, we don't have thromboelastography. At AIG, fortunately, we have those machines, point of care testing. But even if you don't have TEG, you can just go by thumb rule. If you are assessing the blood loss, if the blood loss is lost more than 30 to 40%, your thumb rule replacement of blood and blood components
Yeah.
should be activated.
and then in this stage you find even the mental status of the patient is depressed. So when
Yeah,
you see the
drowsy.
patient confused, drowsy,
That confusion, drowsy
Oh,
look is
that's-
ominous.
ominous sign.
That is it's a sign of decreased cerebral perfusion.
Perfusion, yeah.
And the next stage is restlessness and then collapse.
Yeah, so that is the state when she requires rapid transfusion. Remember that. This class 3, you could have just given her that and replaced the blood volume. But at this stage, if you don't do things fast, you will lose your patient. Now, there is something called ABC. Now, remember, CABD is something different which you do for cardiac arrest. Now, this is something different. Dr. Sunil, can you tell us something more about this?
Again, see, whenever there is collapse, in this case, the collapse is because of massive hemorrhage. And the priority is whenever you have massive hemorrhage is improving oxygen delivery at the cellular level. So, A is nothing but taking care of the airway. If the patient is bled massively, less than more than 40% blood loss, better to intubate the patient and give more good oxygen delivery. So that like GOD, remember God, good oxygen delivery. And remember God for prayers also. So ensure good oxygen delivery by airway and breathing, so you're controlling the ventilation, giving a good high amount of FiO2, maintain what we call as PF ratios of at least 350 millimeters mercury and above, so that the perfusion at a cellular level, at the organ level is better, and you can minimize or reverse the organ dysfunction that happens because of hypoxia. That is one thing. So C is circulation. Circulation again is 2 wide bore cannulas, ensure adequate filling of the compartment, intravascular compartment. With
And to arrest the bleeding.
and
That
the
is, arrest the source. Unless you arrest the source, it's going to be
Yes.
an ongoing
See,
process.
the bucket cannot be filled unless you
Yeah,
stop the hole. So
stop
you,
the hole.
all these things have to go simultaneously. I have to go simultaneously. Again, in this case, I'll just go back to the slide where the patient cesarean section was done and there was an abruption. Probably tranexamic acid usage at that moment of time, or was it done or
Yeah,
not?
that
But,
would
yeah.
have been done
Yeah.
automatically. As
So,
soon as you
yeah.
see the bleed,
Yeah.
the anesthetist gives the tranexamic
So
acid.
circulation is again control of bleeding as well as restoration of fluid
Yeah.
volume, and of course you need to look at the neurological assessment. The mother, if she is drowsy, altered sensorium,
Yeah.
restlessness,
Yeah.
it is a very ominous sign. It's immediate collapse is there.
So I
immediate-
think the most important thing is as you replace, make sure that you have arrested the bleeding. That is very important. That should go simultaneously, hand in hand. And the basic management, as they said in this, it is actually to replace the blood volume and to arrest the hemorrhage.
restoration.
And most important, look at all those, include the neurological status. When you see that, So you heard him say immediately intubate the patient. So, you know, you've got to think of all this. Airway means a patency of the airway. Ventilation is giving oxygen.
Again,
okay?
word of caution, when the patient is extremely acidotic, in this case 7.1 pH, we call it as a physiologically compromised airway. So what is happening is with your spontaneous ventilation, because of negative pleural pressure, you maintain the preload. But sometimes what happens is when the patient is having extreme acidosis, hypotensive, pH of less than 7.1, the moment you give little midazolam, fentanyl or intubate the patient with the positive pressure, the preload is reduced and patient can have cardiac arrest at the time of intubation. So you need to make sure that you resuscitate adequately,
Oh.
start vasopressors,
Okay,
and
okay.
keep the vasopressor anodose ready in your pocket
Okay,
by the
okay,
side, and then you
okay.
intubate the
Yeah,
patient.
that is important. So restore the volume first, restore the BP, and now when we say BP, we call it MAP, okay, the mean arterial pressure. And then you go on to the, so a few tips prevent hypothermia. The hypothermia must be prevented. I can't tell you the importance of that. Keep the patient warm. Hypothermia can exacerbate the coagulopathy and it can also worsen the acidosis. So very, very important. Urine catheterization is very important to make sure there's adequate urine output, because that will indirectly tell you that there is renal perfusion occurring. Okay, so these are few important things in a massive hemorrhage. So look at the sensorium also. These are things which we never look at. Think of the hypothermia, correct that. The rest of the things normally we do, especially putting in a catheter, etc. Because that will indirectly tell you the perfusion now, because we're talking all about tissue perfusion now whenever we talk about shock. So, and a vascular access, we normally insert 2 large caliber. We all know about the 16 gauge gray cannula. And remember, it is always important in a condition like this to immediately put in the peripheral lines first, because very quickly it will collapse. Then you will have to rely on your central lines. So get your peripheral as soon, before you even look at the patient, go fast and get it. And it is said that short, large caliber peripheral lines, they transfuse rapidly much more than the long, thin catheters. Okay? So do that. The sites they choose are the forearms and the antecubital.
Again, I would add, I also put arterial line. Wide bore cannulas, arterial line
Yeah.
suffices most of the major things. Central line may not be immediately essential at this juncture if you don't have the expertise, if you don't have the ultrasound guidance. But importantly, have 2 large bore cannulas and at least put a arterial line, especially when you have an anticipated event or even if it's unanticipated, because once the mother becomes pulseless, then even
Correct.
to get an arterial trace becomes difficult.
Very difficult.
And NIBP recordings in extremes of blood pressure, very high or very low, will be erratic. You won't get the true reading.
Yeah. Do you all do the intraosseous
Touch wood, so far we have not had that scenario.
privilege of doing it?
I would say, because the extremes, with ultrasound availability, you can just put a neckline. It's very easy. But yes, if you don't have those things, then intraosseous is very helpful. The head of humerus or tibial, shin of tibia.
Normally the proximal tibia, the humeral head and the sternum. Sternum normally is not used so much, but you can transfuse large. It is said it's easier access, higher success rates. I have no clue about it. Least interference to the chest compression. So that's very important. The patient will be resuscitated, so don't do anything in the upper part, okay? And pressurized system is required. So the initial fluid therapy, we heard all about it, but Dr. Surya, I want to ask you one thing. You were talking about the balanced ringal lactate. Have we to ask separately for that, or is it, when I say ringal lactate, does it mean?
No. Yeah, ringal lactate is a balanced solution.
Okay, I just wanted to ask you that. So we all know that whenever we give crystalloids, we should give it in the ratio of 3:1. So that means if the blood loss is 1,000, we give 3,000. Okay, it is 3 times, because crystalloids within 1 hour, 20% has already gone to the extravascular space, and there's very little left in the intravascular compartment. So whenever you're giving, that is only the initial resuscitation. If she is going to shock, blood for blood. If she has lost blood, you have to replace blood. So massive transfusion protocol, just a few words about this before we go on to the next. Massive transfusion, normally we say that when a person requires more than 10 units of PRBC in 24 hours or 4 units in 1 hour, and the balanced ratio of PRBC plasma platelets. Let me ask you, Dr. Ranjit, do you believe in this 1:1:1 ratio, or is it gone, or what do you think about it?
Maybe the exact ratio may not be that relevant. The idea is to maintain the proportions of the blood, that the coagulation is maintained. So you don't pump with RBCs. Probably you need to have the proportion of platelets. So it's easy to do at 1:1:1 because basically if you want to do a MTP, your blood bank has to be well in tune with your emergency team or the OR team or the ICU team. So I think to make things simpler, simple formula of 1:1 is not a bad idea, even though it can be argued.
But do you all still believe in that? You all have got any difference of opinion?
Ma'am, the idea would be to initiate. See, if you want to start an MTP, it has to be thought at the point when there is a bleed. So I don't think you need to wait for the labs to come back. If you see that now it's an ATLS 1, if you think it's going to be 3 in no time, probably you have to call up the blood bank.
Okay.
And the idea is you have to assign a person who has to call up the blood bank and tell them by name, and get a person in the blood bank by name and send people running there, get it back.
Yeah.
So that is a protocol. So if you want to run protocols, you have to have written protocols. So 1:1 is in protocol, or 1:2 or certain things that you can actually debate on it, but you have to have a written protocol.
Okay.
Or you can, if it's not such a massive MTP scenario, then I agree with the point that you could go with the coagulation.
Fine. So understanding sequence of events in hypovolemic shock, in the early hypovolemic shock, tachypnea which causes respiratory alkalosis followed by metabolic acidosis. Right? No treatment is required, but a long-standing or severe shock leads to metabolic acidosis, as it happened in our patient. And as I told you, one way of preventing it is preventing hypothermia, because that will exaggerate the metabolic acidosis and the coagulopathy. And long-standing, what happens is they go in for anaerobic metabolism, and then you'll find inadequate tissue perfusion and the lactates rising. So inadequate resuscitation or ongoing blood loss is that is the cause for persistent acidosis. Therefore, you've got to treat the metabolic acidosis with IV fluids and steps to control hemorrhage, as I told you all. The base deficit and lactate values. Base deficit, you would like to tell me something about it, Dr. Sunil?
Thing is, yes, see, normally if you look at the blood gas analysis in parturient, it is a little different from non-pregnant women. Because again, look back the physiology, the minute ventilation increases by almost 45% in pregnancy. So to compensate the excess CO2 wash, the bicarb is lost in by the kidneys as a part of this compensation. So the normal arterial carbon dioxide tension in pregnancy is about 28 to 32 millimeters of mercury. Non-pregnancy is 35 to 42. So a PaCO2 of more than 35 is considered to be respiratory failure in pregnancy, unlike a non-pregnancy. Second thing is,
so in other words, can I just interrupt you? So in other words, what do you find in metabolic acidosis? What happens to the
So what happens is, to compensate this excess CO2 washout, the renal excretion of bicarb happens. So normally in non-pregnancy, if you look at the bicarb level, it's about 24 to 28 millimoles per liter. In pregnancy, is 18 to 22 millimoles per liter. So that means pregnancy is a mildly metabolic acidotic state.
Correct.
So minus 2 to plus 2 is normal non-pregnancy. In pregnancy, it's up to -4 to +4.
And the more the minus it becomes, the more for metabolic acidosis.
More than -6, more than -7, you can't sit.
You can't sit. The plus is good.
Plus.
Okay, if the plus is good, if it is more minus, then it goes more the base deficit, she's going for metabolic acidosis. So hypothermia to be prevented at all costs. Preheat fluids, that's very important. Don't give, straight cold blood product should not be given. At least bring it back to room temperature, otherwise again they go in for hypothermia. So few tips is MTP 1:1 is no more used. Instead you maintain the platelets at more than, as Dr. Ranjit was telling you, maintain the individual products at 75,000 platelets, fibrinogen more than 200, that should be your aim. And the PT INR less than 1.5, that is your INR. PT is nothing but the PT test by the control, okay? And that tells you the INR. So it should be around 1.5 INR. Vasopressors preferably given through the central lines. Can you tell us why, Dr. Sunil, why do you give the vasopressors through the central lines?
Again, during crisis, you can give vasopressors always to the peripheral line, because not everybody is used to putting central lines, and in the process of doing central line, you may waste time in.
Yeah, but they normally say that initially you can give it through the peripheral lines, but later on it's better to give.
What happens is, whenever giving vasopressor to the peripheral line, there is vasoconstriction.
Constriction there.
The extravasation, you may not reach, the vasopressor may not reach myocardium. So it's always better that you give vasopressor through central line so that it reaches the site of action, that is
Yeah,
myocardium.
right.
Yeah.
And about the IVC collapsibility, Dr. Suri, you would like to tell us, you were telling us something about it. Where do you actually place the
Yeah.
probe? See, no
So-
more do we go to the CVP. We can actually immediately, as she was telling about the fast, you got to immediately do the ultrasound and you can find out how the IVC is. If the IVC is full, she's adequately perfused, okay? She's got adequate intravascular volume. If it is not, if it is collapsed, immediately it tells you that there's hypovolemia and you got to check it out. Dr. Suri, could you tell us how you do it
Yeah,
in
so
a minute?
yes, so you have put the probe in the right, you have shown the picture. So around 3 centimeter from the right atrium is where we put the probe, and then you see this is important in a spontaneously breathing patient. In a ventilated patient, it is difficult to
Okay.
interpret. I think he will tell that it is definitely not used in that, but
Okay.
for spontaneously breathing patient, this is a very good test. During inspiration, you see it is collapsing between 1.5 to 2.5 centimeter. The IVC diameter is a normal diameter,
Okay.
and if it is collapsing more than 50%, that means she is fluid responsive. You can safely give a bolus of
You know what
fluid.
she means by fluid responsive? You have got to give her fluids and she will respond to
Yes.
it. That's what she means. Yeah. So obstetric shock index, there are few changes. We all know about HR, that is a heart rate. We don't talk about the pulse because in that patient you will not get her pulse. You will get only a heart rate. Do you understand? The periphery would be cold by then. So heart rate divided by the systolic BP. And if it is more than 1, it's bad. If it's more than 1, it is bad. Okay? And the modified shock index is heart rate divided by the mean arterial pressure. And the respiratory adjusted is heart rate divided by the systolic into the respiratory rate divided by 10. Dr. Sunil, you would like to tell us one word about that?
If you look at the tissue perfusion, the tissue perfusion happens not because of systolic blood pressure, but because of mean arterial pressure, because that is the pressure that drives blood into the cell, and hence what we look at is the modified shock index, where instead of systolic BP, you go with MAP. And when the patient is breathing spontaneously, we know that the spontaneous breathing patient, the negative pressure and the preload is better. So if you want to get a true picture of shock index, you need to take into account
The MAP.
preload also.
Yeah,
So,
right.
yeah.
Fine. So we'll start checking that. In fact, I wanted to ask him to tell you more about the blood gas. But in 1 minute, can you tell us how to look at the blood gas? The pH should be between 7.35,
Yeah.
45. There are ways of remembering it.
So as I said, pH is 7.4. When anything less than 7.33 or 7.34, you need to be get alarmed.
Don't look at the venous side,
Yeah.
look only at the arterial
Yeah,
side. okay?
arterial. And PO2, pregnancy is a hyperoxic state, so 95 to 105 is what the normal PO2 is. Anything, so try to maintain PO2 at least more than 80 millimeters of mercury. And PCO2, as I said, 28 to 32, but not more than 35. And SO2 is very important. So SO2, suppose if you get a pH of like 7.36, but SO2, if you see the venous side, SO2 is 70%.
Okay.
So suppose if you are doing a venous puncture, if you want to do arterial puncture and you by inadvertent you get a venous sample, how do you identify the venous sample or arterial sample? Look at the pulse oximeter. So SpO2 and SO2 should coordinate. Suppose
Okay.
if SpO2 is 98 and SO2 is 70, that means a venous sample.
Okay, okay.
So
good.
that's
Thank
one
you.
of the
Yeah.
things that you need to remember.
Yeah. So this is one thing you have to do, an arterial blood gas, okay, in all these critically ill patients. Now we'll come to the second case. She's a Mrs. S, 30 years old. She's a para 3 live 4. She's got a previous 1 vaginal delivery and previous 2 cesareans, no comorbidities. She went back home after the cesarean and she came back on the 21st day following elective cesarean with complaints of abdominal distension and dyspnea on exertion of 1 week duration. The patient was conscious, her BP was 150, her respiratory rate was 32, she was tachypneic, her temperature was 103, her pulse rate was 130, her SpO2 was 91 with 6 liters, bilateral creps per abdomen distended, guarding was present with diffuse abdominal tenderness, the bowel sounds, they were just about present, the uterus was subinvoluted, there was serosanguinous discharge from the abdominal wound as well as per speculum. So what is your opinion, a gross opinion on this, Dr. Ranjit? When you see a patient with post-cesarean with these
Yeah, obviously this looks like a sepsis.
sepsis, yeah.
Looks like a postpartum sepsis.
Postpartum
Probably
sepsis.
she's post-operative,
Yeah.
and rest of the things, including the vaginal discharge plus abdomen, looks like maybe endometrial infection or the wound infection of postpartum
Yeah.
operation.
Adds on to it. No?
And obviously she has features of shock also.
Yeah. And her hemoglobin was 9.1, her total count was 34,000, her bilirubin was 3.2, SGOT, SGPT 191, 230, blood urea was 43, creat 1.9, her CRP was 113, her procalcitonin was 22, her blood culture, vaginal swab was sent, her lactate was 9.1, serum electrolytes were normal. So what all tells you that this is sepsis from these parameters, 1, 2, 3, 4?
Basically, this multi-organ dysfunction, there's an organ dysfunction is there. There is features
Correct.
of, there is fever, there is the procal is high. So probably there is an infection, probably bacterial infection. So probably there's an infection with features of organ dysfunction.
Yes.
So that fits into a dysregulated response of the body to an
Correct.
infection.
Correct. So as he said, it also looks like she's gone in for a multi-organ damage because the liver is damaged, the creatinine shows the kidney is also affected. Procalcitonin is a marker which will tell you about bacterial infection, okay, sepsis. So the investigation X-ray showed a bilateral mottled appearance. The ultrasound showed moderate ascites with fluid-filled loops and sluggish peristalsis. The CECT showed small bowels were distended. There was moderate ascites with diffuse enhancing thickening of the peritoneal folds, loculated ascites, diffuse or mental mesenteric fat string, suggestive of peritonitis. So at this point of time, Dr. Suri, you would like to do something? This is the order of the things which we sent. We sent a serum lactate, we did a blood culture, and we started her on antibiotics, piperacillin, Tazobac, Metrogyl, and we had planned. Are we right in what we thought of?
Yes, so absolutely. I think the immediate management when you are suspecting sepsis, the right steps have been followed here. That first is that the resuscitation before we do the source control. So the part of the resuscitation, you have taken the blood sample for the ABG, which will show us the lactate level, and guided by the lactate level, we will do the fluid resuscitation. And alongside, of course, we take the blood cultures and the other samples which you have already mentioned. And then within the first hour, we should give the broad spectrum antibiotics which have been given to this patient, the piperacillin tazobactam combination nowadays. But because of the widespread drug resistance, the sepsis guidelines which have been released in 2023, they are giving a much higher, advocating a much higher dose.
So, I'll show you that
yes,
actually.
piperacillin, tazobactam, this 4.5, they have, this is what we have been always giving, but now it is recommended that you give
absolutely,
19 gram as the loading dose, and then after that 4.5, 6 hourly rather than 8 hourly.
Yeah,
So
I'll show you that actually. Actually,
yeah.
I've got those guidelines here. Intraoperatively, when we opened up, as she said, these are the 5 things you should do. Send the lactate, you send the blood culture, start the IV fluid resuscitation, antibiotics, and then go in for the definitive. So this should be the protocol in sepsis. So right enough, we opened up the patient and we found there was seropurulent ascites, extensive edematous deletion over the omentum. There was an infected uterine wound, pus pouring through the wound. Both the tubes and ovaries were edematous. The bladder was densely adherent. There was no obvious bowel injury or appendicitis. We proceeded with hysterectomy because we have to control the source of infection. And we had a bladder injury which was repaired, and adhesions were separated. The abdomen toileting was done, an intra-abdominal drain was left, and a continuous bladder drainage. We wrote the instructions for at least 14 days. 2 pints of PRBCs were given, and she was continued with the ventilatory support for the next 2 days. And with that in mind, we shifted her to the ICU. The abdominal distension persisted. On day 4, she had several spikes of vomiting and abdominal distension, which was better with symptomatic treatment. And then we did a repeat ultrasound, and believe me, there was multiple small bowel loops on both sides of the umbilicus. The pelvis shows thickening and reduced peristalsis, adherence, and both lungs atelectasis. You heard him say that this morning. So we had managed conservatively with IV fluids, antibiotics and Ryle's tube. We tried avoiding another laparotomy, but on post-operative day she started developing high spikes, fever, persistent pain, abdomen, pulse rate went up, the BP went down to 90, 70. When you see that, that means she's going to septic shock, okay, when you see hypotension. And the abdomen was grossly distended, her counts was raised, multi-fluid level in the X-ray, abdomen showed again, the CECT also showed there was evidence of intestinal obstruction. And so to save her life, we went for an emergency laparotomy. The operative findings were moderate ascites, matted loops of gut. All what we see, what happens is when you take a decision a little early, you can avoid a resection. So the intestinal, we only had to separate the lesions, and that was separated. Peritoneal toileting was done by the surgeon. Abdomen was closed with the drain and the patient shifted to critical care. Fever spikes reduced, the distension bettered, and IV antibiotics we continued, and she was discharged on post-operative day 25 after a very stormy post-operative period. Now I want all of you all to know sepsis. When I say infection or when I say an SSRI, that is just a wound site, surgical site infection, which is not sepsis. Overwhelming infection is called sepsis, okay? So sepsis is defined, as Dr. Ranjit was saying, is defined as a life-threatening organ dysfunction with a dysregulated host response to infection. The Surviving Sepsis campaign, you know, it has gone through several stages. In 2018, they told us the first thing you should do is at 3 hours, within 3 hours and 6 hours, but now it has come to the first hour. You've got to do all those 5 things which I told you in the first hour, and now it has been further updated. So that when we say MODS, when there is more than 2 vital organs have undergone dysfunction. So now this is what I want your opinion on. Where does SIRS stand now today with sepsis? Dr. Ranjit, do we still talk about SIRS? Because when I was reading through the 23 guidelines, I realized they were saying that there are still a lot of inflammatory markers and things like that. So what do you think? Do you think SIRS has got a place now?
Ma'am, these are actually the ways of actually picking up sepsis.
Correct.
You know, basically,
Correct.
you think of sepsis.
So
the idea is
we
to
shouldn't lose them, isn't
you
it?
should not lose
we should
them.
not lose
It was
them.
replaced by something, or it was probably the Q sofa which came in was
Yeah,
actually
correct,
used more.
correct.
It is very easy to use because this needs some laboratory stuff also, because WBC counts are there in SIRS. In Q sofa and all, actually it was a respiratory rate more than 22, drowsiness or a BP less than 100. So it could pick up easily. It did not require the lab thing, but there are a lot of debate on that. Now, currently, we believe SIRS still has a role, and you could go by the SIRS criteria to
Yeah.
pick up sepsis.
So it's very simple actually. You can go by the temperature, that anybody with temperature we all know, right? And even hypotension counts, okay? The respiratory rate, as he said, 20, more than 20, heart rate more than 90, the WBC count raise, we know there is sepsis, and PCO2 will tell you about the alveolar ventilation, so it should be around 35, 45. If it is less than 32 millimeters of mercury, tells you. So we used to say that any 2 of the following, the patient has got sepsis, okay? And then we said that you should, when we suspect sepsis, and I told you some time back, if the patient has got a persistent hypotension, she's going for septic shock. This I have simplified the statement.
Excuse
Yes.
me, ma'am, it's like if you have SIRS criteria plus an infection, then you call it sepsis.
Correct,
The
plus infection.
The basic idea was SIRS can be because of trauma, it can be because of a lot of things.
Correct.
So SIRS is basically inflammatory response that the body generates.
Yeah, exactly.
And you have an infection with that, but you think of sepsis whenever you say SIRS.
Correct.
In an IP patient is that scenario.
You know what he said? Because I forgot to tell you that the patient already had evidence of infection. That plus these SIRS will tell you sepsis. Okay, and severe sepsis is when there's end organ damage, which he said already that our values showed. And when you see a lactate of more than 4, normally we say more than 4 is bad. Now we should pick up sepsis when the lactate is more than 2 itself. And you heard Dr. Suri tell you this morning, even if it is more than 1. So lactate actually tells you that there is tissue hypoxia, there is organ dysfunction, organ failure, right? So you said even more than 1 is bad, right? Got to start thinking of sepsis. Dr. Suri, that's what you told us this morning. Oh, I don't.
More than 1.5 actually.
More than 1.5. So though we said 2, even more than 1.5, start thinking. And we say when there is irreversible hypotension, and then she's gone in for end organ damage and lactates rate, she's gone in for a septic shock. These are all the organs that sepsis can affect. It can affect the lungs, she can have an ARDS. It can affect the kidneys with acute tubular necrosis. It can affect the cardiovascular system with hyperdynamic hypotension, CNS, metabolic encephalopathy. She can go in for a DIC, prolonged paralytic ileus, liver acute hepatitis, adrenals acute adrenal insufficiency. So any of these organs, any 2 organs affected, it is actually she's gone in for. So the tissue, yes. Dr. Ranjit, can you tell us more about tissue perfusion variables?
Basically, the idea of circulation is to get tissues, blood and oxygen and maybe glucose into the metabolites in tissue. So basically, the idea of sepsis actually is reduced tissue perfusion in that sense. So it's not even hypotension. Hypotension is a part of shock. So you can say that a person is shocky without being hypotensive. The patient has increasing lactates, and actually it's a compensated shock maybe in the initial phase. So these are all parameters that are shown here, like the mentation, the urine production, the capillary refill time, your serum lactate. The serum lactate is it's a downstream marker of global hypoperfusion, including cellular dysfunction. There are multiple reasons lactates increase, but generally lactates are very sensitive, and it has to be, that's why, Surveying Sepsis campaign has lactate as one of the primary things to be looked into.
Yeah.
So these are all things which probably the variables which are
See, and a simple bedside test, the delayed, it is more than 2 seconds. Your delayed capillary filling tells you it's poor perfusion. So it's all small things which you can actually do, which will tell you that the tissue perfusion. Now I'll just quickly go through this, just to tell you all that sepsis is, now this is a 23 update. Sepsis is currently considered a result of several mechanisms of both pro and anti-inflammatory mediators. Cellular modifications and the importance of microcirculation has been picked up here. And in this context, endothelium has been identified as a fundamental functional unit in the pathogenesis of sepsis. The glycocalus is a component of the endothelial membrane, and damage to it can occur due to oxidizing agents like all your cytokines, endotoxins, etc., and causing increased vascular permeability and worsening tissue perfusion. The updates are the sepsis 3. Yes, Dr. Ranjit, you can tell us more about this. Sepsis 3 started the queue.
Yeah,
quick
this
SOFA.
is what I was talking about. Q SOFA is the one of the methodology which was actually encouraged before this, because you could pick up people with the probable sepsis if you had tachypnea or hypotension at the bedside, and you can systolic less than 100, or GCS less than maybe 14 or 13, and tachypnea respiratory rate more than 22. So these are things which you can pick up very fast.
So this is a quick SOFA score, just 3 components.
Yeah.
You can check the BP and you find the BP less than 100, okay? Some of them they say less than 90. And an altered mental sensorium, Dr. Surya was telling me yesterday, even though we say 15 is a GCS scoring, right, normal. Anything less than 15,
Correct.
she said, is abnormal,
Correct.
she said. That's why he said now 14 also is
14
abnormal.
is confusion.
And if you see tachypnea is a marker of sepsis. You understand? Immediately pick it up. Any 2 of this will tell you that she has gone in for severe sepsis. And this is the quick SOFA scoring to tell you the end organs. You look at the last part of it, 0, 1.
This is a real SOFA score. This is a full SOFA score.
Yeah, full SOFA score.
Earlier was a quick SOFA, Q SOFA, which you just showed now.
Yeah.
So the quick SOFA, if you had two things out of 3, you could think of sepsis. So actually it was planned for an easy pickup of sepsis. But the problem was it was not as sensitive as cirrhosis and all, so you could actually miss on sepsis, because it was not validated for picking up of sepsis. That is a current controversy, and currently the guideline in 223 guideline doesn't kind of encourage QSOFA as the primary screening tool.
And then you saw that this is a very important ratio, the PaO2 by the FiO2. The more it is, if it is more than 400, it is good. Look at the last scoring, it is less than 100, the score goes up to 100. If it is less than 100, it goes up to 4.
That looks like an ARDS when you have such a bad
exactly, an ARDS.
PF
Picture coagulation, you see, look at the platelets, less than 20,000. The last column says the liver bilirubin more than 12, the cardiovascular hypotension with the dopamine and norepinephrine, etc. The CNS, you find the GCS score has gone to less than 6 and the creatinine less than, more than 5. So this was a quick SOFA scoring.
There is SOFA is not a diagnostic tool for picking up sepsis. It's a mortality score.
Yeah, exactly.
It tells you how bad is your sepsis.
Yeah. Now there is something called the modified, Dr. Sunil, you would like to tell us about that, the modified, obstetric modified SOFA sepsis?
Again, this was a scoring that was done that came from Australia, New
Australia,
Zealand,
New Zealand.
so SOMANS, like Society of Obstetric Medicine, New Zealand. And if you see the conventional SOFA score where we have 0 to 4, this is just concise, 0, 1, 2. So just basically you truncated the scoring system, but parameters are more or less the same thing. So you pick up early, you don't wait for the PF ratio to drop less than 100. So you're trying to pick up early and act early. One other thing that has to be reiterated is our one bundle antibiotic has been rightly said, lactates, blood cultures, antibiotic. Every hour delay in antibiotic administration in the patient's septic shock is going to increase the mortality by almost 10 to 15%. So it's like a medical emergency. Septic shock is a medical emergency, life-threatening medical emergency, I would say.
Okay, so the most crucial things are the hour one bundle, in which I told you all, you send the cultures, the antibiotics have got to be started after that, the lactate measurement, the broad spectrum, the crystalloid replacement, and if after crystalloids the BP doesn't pick up, then you've got to give vasopressors.
Again, madam, just
Yes.
you don't have to wait for 20 to 30 ml for crystalloid to go in.
Yeah,
If the
that is
pressures are
gone.
not picking up, you can straight away bang on start norepinephrine, at least double strength norepinephrine. Thumb rule, take 2 ampoules in 50 ml syringe with normal saline and just start with 5 to 6 ml per hour. Try to maintain MAP of at least 65 and above. And again, you don't have to go to the supranormal like 0.5 mics per kg per minute NORAD. You can straight away, if the pressures are still low, you can start vasopressin also. So basically, everything has to go simultaneously. You don't have to wait till the entire fluid goes, then start norepinephrine, till you reach the supranormal dose of norepinephrine, then you start vasopressin. I think you can take the decision,
Yeah.
but aim at maintaining MAP of 65 and above so that you improve the tissue perfusion. You improve the MAP so that the tissue perfusion, the cellular perfusion improves.
See, you know what, MAP less than 65 is bad, okay? The mean arterial pressure less than 65 is bad. So we try to keep it above that level. That's what he was saying, you will have to increase the fluids and the vasopressors, etc. You heard Dr. Suri tell you about the antibiotics. This is what they have said. You can give piperacillin, you can give meropenem, you can give daptomycin, vancomycin, and caspofungin is when you suspect when there's a fungal infection. So because your sepsis can be due to bacterial or even fungal, right? So you'll have to think of all that when you start. And as he rightly said, earlier on we used to say fluid resuscitation was 30 ml per hour. Okay, that has been questioned now. That has been questioned. So even 20 ml.
Targeted.
Yeah, targeted. So crystalloids, as we heard them say so much about it this morning, and the colloids, and the amount of fluid that has been debated, the 30 ml per hour has been debated. So after that, the first, yes, and Dr. Sunil, you would like to tell us about the vasopressors, the drug of
Yeah.
choice?
Again, restrict fluid. Don't give fluid because sepsis, excessive fluid administration in sepsis patient is bad. So you need to maintain isobalance. Probably initially when you're resuscitating the patient, you can give little more, but on the first post-op day or second post-op day, always go for isobalance or negative balance so that you are reducing the third space collection. Again, along with fluid resuscitation, simultaneously start vasopressor. Norepinephrine is the vasopressor of choice in even in pregnancy, and you can, as I said, you can take double strength, 2 ampoules or 4 ampoules in 50 ml, and then maintain MAP. Again, if you're not able to maintain despite norepinephrine, vasopressin seems to have be acting further because it increases the SVR and it improves the MAP also. Again, you need to remember that whenever you're using vasopressors and in sepsis, there is always an element of cardiovascular dysfunction. There may be myocardial dysfunction, there may be myocarditis also. So if you have any cardiovascular element and if you do a transvasovagal ejection fraction is low or patient has underlying heart disease, complicating pregnancy and septic shock, then go for norepinephrine, vasopressin and low-dose dobutamine.
Dobutamine.
But again, you have to remember that dobutamine can cause peripheral vasodilatation also. So dobutamine versus adrenaline. So basically mix of ionodrops and vasopressors, that's the way that you maintain the contractility, you maintain the SVRs and you maintain the perfusion, and you have to see that the lactate which is increasing should start reducing trend.
Okay. So basically this is the order. They first start with NORAD, then the vasopressin and then the epinephrine. And if there's a cardiogenic component, you give dobutamine. So then oxygenation, ventilation, they say the low tidal volume ventilation should be there. I have no time. So along with that, remember one thing, this is not the only management. You may have to give her DVT prophylaxis, you may have to give her insulins, you'll have to give a proton pump inhibitors, renal replacement therapy. I don't know more about it. Anybody can enlighten me on that? What is
Again,
that?
as I said, basically it's just dialysis. So when the patient has
Oh.
persistent elevated lactate, low pH, low bicarb, and despite inotrops and vasopressors, pressures are not improving, the creatinine, there is no output, then you can go for early CRRT.
Oh,
In
that's
fact,
what it means,
yeah,
is
you
it?
can you
Right.
can you can use different filters also so that you can absorb the toxins, hemodiafiltration and other things. So basically, it's a modality where a conventional hemodialysis is like, as you saw in first case, patient is having raised creatinine, you hemodialyze the patient. But in septic shock or any form of shock when the pressures are low, patient will not tolerate hemodialysis. They need to go for a low volume, continuous renal
Okay.
replacement therapy or
Okay.
a sled.
Okay,
So
okay,
it's a
got
type
it,
of dialysis only, but it's a basically slow filtration.
Slow. And then the steroids, what's the place of steroids in sepsis now?
Again, whenever there is overwhelming sepsis, there is adrenal insufficiency. And whenever there is adrenal insufficiency, you can straight away go for 200 milligrams of hydrocortisone
Okay,
per
right.
day as a continuous infusion or 50 milligrams 6 hourly.
Okay, right. Thank you. And then, so this is what Dr. Sunil calls it as a pancha mantra. Measure the lactates, the cultures, the antibiotics, the IV fluids. Though the 30 ml has been questioned, you need give only much less now. And then the vasopressors. Now, we'll quickly go to the third case. It's a 30-year-old, a Gravida 3 para 2 with previous 2 full-term vaginal deliveries, 30 weeks of pregnancy. She was admitted to the cardiology department with features of acute pulmonary edema. She had undergone a balloon mitral valvotomy 3 years earlier, and she has now developed a mitral restenosis and pulmonary hypertension. Her blood group was AB positive. Clinically, she was in frank pulmonary edema, and she improved with anti-failure measure. Could the situation have been prevented, Dr. Govinduni?
Yeah, if she had come before pregnancy, I think there are two questions here. One, she comes to me before pregnancy, and two, she comes to me in early pregnancy. Now, one of the points we have to think here is that she already had a balloon mitral valvotomy 3 years ago, and then has developed restenosis. That is not usually very common. When you do a balloon valvotomy, it takes much longer for a restenosis to occur. That tells me that this valve is actually not a good valve for balloon valvotomy.
Oh, that's what you think. I thought it was a regurg. She already had
No, it is after all a mitral stenosis only.
Okay.
So if she has come to me before pregnancy, doing another balloon is not an option. So she has to go for either a mitral valve repair or a replacement.
Replacement.
And repair in a rheumatic heart disease is very difficult. So if we go back to
Okay.
replacement.
Okay, okay.
If you replace with a prosthetic valve, the oral anticoagulation and lots of problems during the pregnancy. So that means we have to decide whether she wants a child or not. If she wants the child, then she should have a bioprosthetic valve, tissue valve, where you don't require an anticoagulation. But the problem is bioprosthetic valves degenerate faster compared to metallic valves which go on and on and on for 20 years maybe. So that will be what I would do before pregnancy. The question will be, does she want to have another child? If so, a tissue valve. If not, a metallic valve.
Okay.
If she comes during first trimester, then it is again very problem because you cannot do a balloon again. Obviously, the balloon has failed. So I think she will have to terminate the pregnancy if she comes early during pregnancy and then
Okay.
decide what next to do.
Okay. And then what happened was she required non-invasive ventilation as she was dyspneic. Echo showed severe mitral stenosis with moderate mitral regurg and moderate aortic regurgitation. There was severe pulmonary hypertension. She improved on medical treatment and she was discharged after 6 days. Then she was readmitted again at 34 weeks with the same complaints of dyspnea and her hemoglobin was only 8 grams. She had bilateral creps. The ECG and the echo, they showed left atrial enlargement, right axis deviation, right ventricular hypertrophy, all features of severe pulmonary artery hypertension due to mitral and aortic valvular disease. Now, what is your diagnosis at this point of time?
One thing I would like to add is when you asked me it was mitral regurg, I said no, it is mitral stenosis. Before the echo was because regurgitation patients usually tolerate the pregnancy well. Only long-standing regurgitation with LV dysfunction will have complications. That is why I thought it was more likely to be a stenosis. Now at this point of time, obviously she is in 34 weeks, so her heart is definitely, cardiac output is very high, plus her hemoglobin is only 8. So maybe all of those has contributed to the worsening at this stage of time. So this stage, 34 weeks, I don't think we can do anything other than giving her good dose of diuretics, maybe reduce the heart rate with some beta blockers. I think that is all what we can do.
Okay, and then what happened was, on admission, the dyspnea worsened and she was put on non-invasive. She went into spontaneous labor and she delivered a preterm babe. Baby cried, she was having maternal tachycardia and but after the transfer to the ward, and she continued to have dyspnea and cough. A pulmo consult was done, a sputum was checked for AFB. Patient's condition improved with medications and she remained comfortable. On day 14, she had an onset of fever. And with that, her dyspnea started increasing again. Her BP was 150/72, heart rate went up to 102, her SpO2 dropped to 82 on room air. And then, as you rightly said, we gave her Lasix and NTG, was it right?
Yeah, NTG does produce some pulmonary vasodilatation, which can
okay.
reduce too.
Okay. And at 6:40 p.m., the patient became hypoxic, had to be intubated and ventilated. She was given methylpred. Why?
I really am not sure
Okay.
why it is
Anyway,
given.
she was given, and she developed bradycardia, and then atropine was given, then she went for asystole. This is actually taken from from one of her maternal deaths. And then she remained stable on inotropic drugs, dopamine and adrenaline. Then she went into a brady, her sugar dropped to 68, and then she went in further for hypertension. The drugs were repeated, and she went into an asystole and no spontaneous respiration, and she expired at 2:35. So what interventions could have been done, at least during the postpartum, to have saved her life? Because she went walking from the labor room, right?
Yeah, I think it is difficult to answer because she had actually gone through the pregnancy and delivery. Even though a stormy course, she did come out of the delivery without any problems. So one would have expected that there would not be any more problems, and we would have, as I said, the option is mitral valve surgery, and we would definitely have waited maybe for a year till the child becomes, till she can look after the child. We would have definitely waited till then. So why did she have problems on the 12th postnatal day? I think we have to look at the classical usual question: what are the things that will precipitate heart failure? Maybe she has gone into atrial
Yeah,
fibrillation.
she had fever actually. Suddenly she
Yeah.
developed a fever.
The
I
common
think that
cause.
tilted the balance, I think.
Yeah, the common causes are one, atrial fibrillation. We really do not know whether she has gone into atrial fibrillation.
So-
Second is obviously infection. Third may be anemia. Four may be a pulmonary thromboembolism because she already has severe PAH. So a small clot from the pelvis can really create havoc, tilt the balance against her.
Okay.
So all these one has to consider.
So what are your anti-failure measures today? What should we know as an obstetrician?
No, I think this is different because when we are talking of mitral stenosis, the left ventricle is normal. So whatever we are talking about heart
it is
failure
irrelevant,
are
yeah.
due to heart failure when there is a myocardial dysfunction. Whereas here it is only mitral stenosis. So none of these will work in mitral stenosis. In mitral stenosis, the only thing that will work is reduce the heart rate by giving beta blockers, reduce the preload by giving a diuretic, and then open up the valve, the result. None of these things are going to help in a mitral stenosis.
Okay. And what are the new drugs that have come into the armamentarium of cardiac failure management?
Yeah, in a heart failure, not mitral stenosis, in a heart failure, we have new drugs like the so-called RNA angiotensin receptor neprilysin inhibitor, which is a combination of neprilysin inhibitor plus valsartan, that is an angiotensin, which has been very good,
Receptor.
found to be very good, but you cannot give it in pregnancy. After all, it is a RAS blocker. We have SGLT2 inhibitors, which came as a diabetic drug, but now has become a foundation drug for heart failure. So these are the two new drugs that have come, which has really revolutionized the treatment of heart failure.
Then what have you got to say about ivabradine and...
They are all second line drugs because the last drugs which are ivabradine, digoxin, vericiguat, none of them have actually reduced mortality. They reduce heart failure hospitalizations, they improve symptoms, they improve the quality of life, including digoxin. So they are second line drugs, whereas the first four drugs actually improve mortality. They are beta blockers, ARNI, SGLT2 inhibitors, and spironolactone, aldosterone inhibitors.
Yeah, but normally we don't give AC inhibitors and
No, you cannot
ARB
give in
or
pregnancy.
ARNI we don't give in
Yeah,
pregnancy.
you cannot give in pregnancy.
So soon after delivery, probably if she was...
Soon after delivery, if say for example it is a peripartum cardiomyopathy, after delivery, if she is breastfeeding, ARBs are questionable. Preferable not to give an ARB. You can give an ACEI, very good. These are all scoring systems on how you go about it.
Yeah, so we know that if the patient goes in for an arrest, we would go for a peripartum cardiomyopathy, peripartum cesarean section within 4 minutes, right? Within 4 minutes, the perimortem cesarean section or the hysterotomy has got to be done, and within 5 minutes, the baby should be out. Now, we won't go into that. Just to tell you the importance of the left uterine displacement, you just watch that, see what happens, how the inferior vena cava gets compressed when the patient is lying supine, and see what happens when it is off. So just 1 more minute of your time. This is a 23-year-old primary gravid at 34 weeks. She had no comorbidities. She was admitted to the labor room. On examination, her BP was 110/80. Everything was normal. Her SpO2 was 98, 34 weeks. Everything was normal. And because she had a little pain, there were no contractions. Injection diclofenac was given to the patient. The patient started complaining of chest tightness, dizziness, nausea, and vomiting. Suddenly, her BP dropped to 80/50. Her SpO2 was 74% on room air. Her respiratory rate went up. Bilateral wheeze. And so, what is the probable diagnosis, Dr. Suri? You'd like to offer something?
So it could have been, and I think it looks to be an anaphylactic reaction.
Which was perfectly normal
Yeah.
until then.
Yeah, because the drug has been given IM, and I think this particular, we have had experiences with Bovidon previously
Yeah,
also.
we have also had.
Yeah, so it is a drug which should be given with caution. So anaphylaxis is what we suspect in this case, and I think the response to anaphylaxis, it should be something which in all the labor rooms and in our wards, it should be mentioned that what is the first line management with this kind of, bronchial constriction and everything. It is adrenaline which has to be given. And, in fact, in many of the places, the trolleys, the sister will label it and keep in the, the ampule, because it takes time. So, because here it is very important
And
to
how
give
do you
it.
give it?
IM is given for the anaphylactic reaction, 0.5 milligram adrenaline, 1 in 1,000, that is recommended for the anaphylactic reaction. If she is also had a cardiovascular collapse, then it is the IV which is recommended. But
Okay.
if she is not had a collapse and it is an anaphylactic reaction, it is the IM, because giving IV can lead to ventricular fibrillations and other problems,
Okay.
So it is not recommended that
So
we
IM
give
is probably best for
yeah.
us.
And we should in fact load these, in the syringe and label it and keep, so that if such occurrence, unfortunately occurs, we can immediately give the adrenaline. But we see normally people will give the AVIL injection and the hydrocortisone,
Yeah.
Those are the second line.
Second
Basically, adrenaline is the life-saving injection,
Okay.
which should be immediately administered.
And then
in
if
such
required,
cases.
we have to ventilate, start
Yes,
IV fluids.
and
go.
of course, because anaphylactic shock, the shock which is occurring is also, again, it is a distributive shock. So the fluid resuscitation is indicated here also. So one can simultaneously give a bolus of fluid,
Okay.
distaloid, and ventilate, give the oxygen, and of course the ventilation if required.
Act very fast, isn't
Yes,
it? Otherwise,
yes.
you lose your patient.
Absolutely.
So in obstetric, we can't cover all the different types of shock, but these are the various types of shocks that you can get in obstetrics: anaphylaxis, anesthetic accidents, bleeding, cardiac, we heard just now, and then drugs can cause eclampsia, help, uterine, AFE, very, very important, uterine rupture, abruptio, Cuvelier, inversion, pulmonary embolism, sepsis, MODS. So it goes on and on, the various things which can give rise to an obstetric shock. So let's hope and pray that none of us get any of these problems in our hands. And even if we get, remember that you should know the ABC of management. And I say a big thank you to my panelists for having enlightened us during this panel. And thank you all. Thank you.
Thank you so much, madam and panelists.